Dr. Sultan Mubashir, and it is such a privilege to be here talking to such an august gathering. Um, my topic is slightly different, and it is about a clinical audit. There's a lot of, I'm sure that colleagues over here are aware of clinical audit. Audit is a term which is mostly used for financial terms, but this time we're using it for clinical. And it is becoming very common part of a clinical practice in developed world, and especially in UK. It was started in 1989, and since 2008, it has almost become mandatory to be part of a clinical audit, to participate in a clinical audit, or to conduct a clinical audit. So my young colleagues and students who wish to go abroad for studies, I think it's time that they should be aware of what is a clinical audit. So briefly, I will discuss before my topic about clinical audit. It is a process of critically and systematically assessing our own professional activities with a commitment to improving personal performance and ultimately the quality and or cost effectiveness of patient care. It is a key element of clinical governance, and the aims of clinical audit is to improve patient care, enhanced professionalism, efficient use of resources, accountability to those outside the profession, and aid to continuing education. So clinical audit presents a practical approach to systematically evaluate the quality of patient care and identify treatment gaps between current practice and target goals. So whatever you are practicing now, you compare it with the standard guidelines and see if there is any gap which you can improve so that at the end the patient gets the benefit. So it is a cycle. Clinic audit is a cycle where we choose a topic, you make objectives and standards, that is what you are trying to achieve. Then you do a data collection and data analysis, and then you implement a change, and then reevaluate. So it's a cycle. So you have to collect. In most of the clinical audits, the data has to be collected either 2 times or more than 2 times. So what's the difference between a clinical audit and research? So research is concerned with discovering the right thing to do, and audit with ensuring that it is done right. So my topic today is a local audit of practices of prescribing antihypertensive medicines in type 2 diabetics in accordance to guidelines published by NICE and ADA. So we are again onto diabetes mellitus, and as we all know that it is a major chunk of disease outside communicable diseases. And in 2030, we expect the diabetic population to be more than 500 million. So, as in hypertension optimal treatment trial found that in subgroup of diabetic patients, the risk of major cardiovascular events was halved in the group randomized to a diastolic blood pressure of less than 80, compared with the target group with diastolic blood pressure of less than 90. Type 2 diabetes mellitus is the predominant form of diabetes worldwide, accounting for 90% of cases globally. Sex, age, and ethnic background are important factors in determining the risk of developing type 2 diabetes. Diabetes mellitus and hypertension are interrelated diseases that strongly predispose to individual to atherosclerotic cardiovascular disease. And hypertension is about twice as frequent in individuals with diabetes as in those without. As we have been going through these presentations, and there's a lot of talk about micro and vascular complications, which are very common in diabetic patients who are also hypertensive. These patients have twofold increased risk of cardiovascular mortality compared to patients with diabetes alone. Studies have shown that intensive blood pressure control has a beneficial effect in decreasing the rate of progression of these complications. There are many evidence-based guidelines for management of hypertension in patients with diabetes. These guidelines emphasize on intensive BP control with monotherapy or, if needed, combined drug therapy. And renin-angiotensin system inhibitors are the preferred antihypertensive drug of choice since a number of clinical trials have documented the benefits of these drugs. Periodic audit and awareness of clinical performance in diabetic care is essential towards prevention of diabetic complications. In insulin-dependent diabetics, beta blockers can prolong, enhance, or alter the symptoms of hypoglycemia. While hyperglycemia appears to be the major risk in non-insulin dependent diabetics. Beta blockers can potentially increase blood glucose concentrations and antagonize the action of oral hypoglycemic drugs. And there is no doubt that beta blockers and diuretics, especially when combined, have adverse metabolic effects and increase the risk of new onset diabetes in predisposed patients. Various guidelines therefore argue against the combination of diuretics and beta blockers in primary prevention among people with a high risk for developing diabetes. Additional protection may be obtained by the use of a blocker of the RAS, either ARB and ACE, and a blocker of the RAS should be a regular component of combination treatment and the one preferred when monotherapy is sufficient. The RAS blocker with calcium channel blocker combination has been shown to be effective by the accomplished trial. There are also known differences in diabetogenic effect between the different drug regimens. A network meta-analysis has calculated the odds ratio for new onset diabetes to be 0.62 for ARBs, 0.67 for ACE, for placebo 0.79 for CCBs and 0.93 for beta blockers compared with treatment with diuretics. So now coming to the audit which we conducted at Shalimar Hospital in the outpatient department and Sakina Institute Diabetes and Endocrinology. The sample were patients, the discipline involved were consultant physician, medical officer, postgraduate trainees, registrar, senior registrar. Standard guidelines we followed was ADA, that is the American Diabetic Association guidelines, and NICE guidelines, that is National Institute of Clinical Excellence UK. And the source of our data was hospital data system. A total of 1099 patients were enrolled with type 2 diabetes who were also hypertensive, and they were followed up for 6 months during routine in medical OPD and specialized diabetic center. We reviewed the patients before and after implementation of hypertension treatment according to NICE and ADA guidelines. Targeted BP control was equal to or less than 130/80 for patients with diabetes and 125/75 for patients with proteinuria. To accomplish BP target, in addition to tailored lifestyle modification, we also frequently tailored 2 or more than 2 antihypertensive medication with frequent BP monitoring as per guidelines. Data was analyzed using SPSS version. In our study, we treated the diabetic and the hypertensive patients with monotherapy and combination and divided them in into 7 categories, namely monotherapy with commonly used drugs like ARBs, ACE, CCBs, diuretics, and beta blockers. We also picked a combination in which other ARB or ACE are used. We also categorized a group in which combination therapy was used without ACE or ARB. We also kept in view the comorbids such as ischemic heart disease and heart failure. Primary data before implementation of guidelines. The number of male patients was 331, female was 768, and the age group showed less than 40 years, 70, between 40 and 60, 609, and more than 60, 420. And the medications which they were using was monotherapy with ARB was 197, monotherapy with beta blockers 94, monotherapy with calcium channel blockers 67, monotherapy with ACE 71, monotherapy with diuretics 60, and ARB combinations 400, with ACE combinations 44, and miscellaneous combinations 166. This is a follow-up data after the implementation of guidelines. The male and female ratio remains almost the same, and the age group is almost the same as well, with slight increase in the population of 40 to 60 years. This was the data after the implementation of the guidelines, with monotherapy with ARB has increased to 364, monotherapy with beta blockers has decreased to 33, monotherapy with calcium channel blocker almost remains the same, monotherapy with ACE is almost same, slightly decreased, and diuretics. And the comparison of both data before and after the implementation of the guidelines shows that ARB has increased, beta blockers have decreased, calcium channel blocker is almost the same, ACE has decreased, diuretics have decreased, ARB combinations have decreased, ACE combinations have decreased, while the miscellaneous combinations remain the same. In conclusion, what we see in this data is that we are using antihypertensive ARB more than any other antihypertensives in these patients, which is almost according to the guidelines. What we noted in our study was that there is less use of ACE. And this seems to be because of increased incidence of cough due to bradykinin effect. In going through the other analysis, we have seen that in European countries, the incidence of cough is less than what it is in our part of the world. In few studies, we have seen the incidence of cough is almost 20% in patients who use ACE. So perhaps this is the reason why we are using more ARBs. The beta blockers have decreased after the implementation of the guidelines, which is what our study was meant to. Calcium channel blocker remains the same, and also in the combinations, ARB combinations, we have seen the greater use of ARB with calcium channel blockers. So, in conclusion, we see that the implementation of the guidelines can improve the prescribing habits of the doctors, which in turn will improve the patient care. One thing which we noted in our study was the increased number of female patients attending the clinics, and this is perhaps because these clinics are in the morning time when the men are usually at work. So with that, thank you very much.